I give the signal.
Yeah, I will start and ask Shreyash to introduce.
We are live.
Okay. Good evening, everyone. Happy to welcome you all on Friday evening. With we have a very well-known faculty to, I think, all the Indian arthroscopic surgeon, Dr. Andy Williams. He had come before to our meetings, and I think all of us known him. I think it's a very good opportunity to catch up with him, and he is going to give a very interesting talk, Return to Sports After Knee Ligament Injury, Where Are We Today? And he said before the live that he is going to give some lot of new informations, which we are going to hear first, so that we are lucky to hear all his talk today, which is going to be a long talk, and I welcome all the questions at the end of the talk. Now I request Dr. Shreyash Gajjar to introduce Dr. Andy Williams.
Yeah. Hello, everyone, and welcome to this webinar on return to sports after knee ligament injury. Where are we today? Knee ligament, especially the multi-ligament knee, is a devastating injury, and the evolution of anatomical ligament reconstruction for these injuries has resulted in improved restoration of joint stability and patient satisfaction. These results have naturally led to greater expectations, especially in the sportsmen, for what level of activity can be achieved. And today we are indeed privileged to have a renowned personality, Dr. Andrew, popularly known as Andy Michael Williams from London, UK. He's an expert knee and sports surgeon with a particular expertise in knee ligament problems and robotic knee joint replacement. He's a reader at the Imperial College London and co-founder of London Musculoskeletal Health Centre Fortius Clinic, an honorary senior research fellow at the Nuffied Department of Orthopedics, University of Oxford. He qualified as a surgeon from King's College in London and completed his orthopedic training at the Royal National Orthopedic Hospital in Stanmore, before undertaking a year-long fellowship in Brisbane, Australia with Dr. Peter Myers. In 2014, he became a member of the ESCA Sports Committee. He is also a broad member at the Bone and Joint Journal, for which he remains a reviewer, and he is a reviewer for the American Journal of Sports Medicine. He was the lead editor of the 39th edition of Gray's Anatomy. To date, he has written over 100 scientific articles, has published numerous award-winning studies on knee motion and ligament stroke meniscal anatomy and surgery. He lectures nationally and internationally on knee surgery. He is a member in good standing of several international societies. He regularly works with many sports personnel, including most Aviva Premiership rugby clubs and many English Premier League football teams. He was named in the Times Britain 100 Top Doctors in December 2011. He is known for treating professional athletes, including international and Indian cricket team players. So overall, he's really the right person from his years of experience to give us and share his views on return to sports after knee ligament injury. Where are we today? So indeed, we are very grateful, Andy, for you to accept the invitation. I'd kindly request you to please share your presentation and talk to us on this topic. Thank you.
I'll just check you can see that, can you?
Yes, we can.
Lovely. So first of all, thank you very, very much, Steve, for that unbelievably generous welcome. If only I could be with you in person, I'd be much happier, but I think you've been very kind to me. So I hope I can respond by giving the talk that you want. As you say, I've got a lot of experience with sports-related injuries and ligament injuries in particular. And this is quite a long presentation I was asked to give, and it covers a number of areas, but really it deals a lot with the philosophy of dealing with ligament injuries as isolated injuries, but also as combined injuries as well. And you'll see for the first time some data we've got of the results of my surgery, but also some basic science that I've been involved with at Imperial College. So I hope it gives a flavor of how we can improve our treatments, how we can improve the results of our work. As you've already kindly heard, I've been doing this for a long time, 22 years, in fact, dealing with professional athletes. And 70% of the people I see in the clinic are athletes, and 50% of all my ACLs are in professional sports people. And as you've already heard, I look after a lot of teams in the UK and further afield. Treating athletes is very useful. It's a fantastic finishing school, if you like, in terms of your training. You learn so much from dealing with them that it makes you better for treating your non-athletic population as well. I've learned so much. I've been very, very fortunate. They're also difficult. They test your judgment, they test your surgery, and you certainly learn what works and what won't work because of the incredible things they do. And you can see that picture on the right. It's one of my players had an ACL 7 months before, doing something I could never even dream of doing at my best as a sportsman. They are special people and they will test what you do to the limit. Just on a note, every athlete whose photograph appears here will be blanked out so they're anonymized. Anyone who hasn't got a blank on their face is not one of my patients. The other amazing thing with them is they cannot escape the public interest in sport, and they're on social media, the internet, and I can follow my patients up with almost 100%. And so over lockdown, I sat down on my backside for 10 hours a day getting data about my cases. And you will be the first people to hear this. 450 athletes, ACLs, for example, 116 multi-ligament cases in athletes. And you'll be the first people to hear the results of these studies. So how do you get best results? Because that's what we've got to really strive for. And it's pretty obvious, really, and I apologize for making such a blatant and obvious statement, but you won't get a good result without making a good assessment of your patient's injury. You've got to make the right decisions, whether you need surgery or whether you don't need to operate. You need the right rehabilitation. It doesn't matter how good an operation you do, if the physiotherapy is no good, it can ruin it. Equally, if you don't do a good operation, there's no physio can fix that. So all aspects have to be correct, and then you've got to choose the right time to return to play. Now, over the years, I've learned a lot, I've become more experienced, and better results are really part of a never-ending learning process. And you've got to study, you need to read the publications of those who do lots of this, do research and publish your results. And you must follow your patients up to learn what's right and what's wrong. Now, obviously, a lot of my patients are professional athletes and they are different. There's no question, it's not their fault, but they are special. And the vast majority of times I see an athlete, the treatment will be non-surgical. And I have to give them a clear plan, the time frames. If you're going to treat them, you cannot avoid attention to detail. It is the secret of excellence. You've got to be thinking and worrying a lot, and then think and worry again and again with every case to make sure you see it through and get the result. One thing I've learned is that if you do an operation on an athlete, you do as little an operation as possible to get the result. Sometimes you might think it's obvious to do the big procedure, but all that matters to these people is performance. And sometimes a big operation won't allow them to perform properly. And of course, if you do an operation, it's got to be right first time. There are no second chances. So first bit of philosophy, really. What does a ligament injury cause? Well, first of all, and obviously it causes laxity in the joint, but often forgotten, it also causes a proprioceptive deficit. Nerve endings fill up ligaments, particularly the cruciates. And even though cruciate ligament surgery is a wonderful thing, which it is, it cannot restore normal proprioception. And so that knee will never be normal, ever. It may feel good, it may even feel normal, but that lack of proprioception is critical. And I'll give you an example. A patient with a varus knee, and many athletes do have varus, ruptures their ACL, nice ACL reconstruction, and they have a reconstruction, they get back to sport, but slowly but surely they'll develop posterolateral corner insufficiency. And the reason for that is they've lost proprioception, and they've therefore lost the dynamic ability to control the varus that limb is stressed into because of its alignment. Normally, it's resisted by biceps, lateral gastrocnemius, etc., TFL. But if you lose your ACL, that muscle control is less good, and they slowly stretch out the posterolateral corner. And that's a real phenomenon. So proprioception is important. And you lose performance if you don't have proprioception. I've just seen a lovely patient who I'll present the case of later on. She said, just doesn't feel right, my knee. She's done very, very well, and you'll see, but we'll come back to her. And she knows, because she's a world-class 100-meter sprinter, that she has to think about her right knee and not her left. If they get back to sport, because they don't have normal proprioception, they effectively have a Charcot joint. And I've had some lovely patients of mine get very excited, get back to sport, and then they've wrecked their knee. The ligament reconstructions were perfect. It felt like a normal joint, but they ended up with a Charcot type problem, got osteoarthritis. And actually, if I have an amateur, I'll often stop them getting back if they've had a multi-ligament injury, because they're going to wreck their knee. So what are we trying to do? We're trying to abolish laxity when we treat these cases, and we're trying to maximize proprioception. And getting the ligament reconstruction right helps proprioception. The brain recognizes a joint that is congruent. A joint that's subluxed is foreign to the brain, and so muscle control goes astray. And so if that joint is lined up properly, the brain may recognize it and your proprioception is improved. You also need time for proprioception to be enhanced from other structures, the menisca, the capsule, when you've lost something from the ACL, for example. And so also when you do surgery, you need to realize that repairing tissues is far better than reconstruction. If you can get a ligament to heal, either by bracing and not operating at all, or by a suture repair, that knee will be more normal in terms of its proprioception than if you just do reconstruction. And it's very important, particularly for the sportsman. So ideally, with a complex case, I want to operate within a couple of weeks. Now, that's not to say I always do that. If the knee is very angry, whether it be just an ACL or whether it's a multi-ligament, I will wait. But if the knee is mobile, it's flexible. And of course, many of these athletes have brilliant physiotherapists, and so they can benefit from that and get the knee ready more quickly. I like to operate quickly. So what I'm going to do next is go through the 4 ligament complexes, some in more detail than others, and eventually come back and put them all together in terms of multi-ligament. So why not start with the MCL? It's the most frequently injured knee ligament. It's very vulnerable to valgus stress, as you can see in these pictures here. And in rugby, we see a lot of this. A player may be protecting the ball, and another player comes in from the side and hits the lateral side of the knee, and they rupture that player's MCL. Now, the MCL is probably the forgotten ligament, I think. I've recently written an editorial in the KSSTA on that subject. There is the view that MCL injuries really are not a problem. In the 70s and 80s, and I'm old enough to have been a registrar in that period, I used to open up knees. I didn't know what I was doing. The results of the surgery were terrible. They'd lose range of motion and still have a lax MCL. Dreadful. So the 90s and 2000s, we were taught never to operate. If you have an ACL, MCL, for example, you brace it, get the MCL to heal, and then come in later on and do the ACL. If there was MCL laxity, the thought was delayed surgery was just as good anyway. But really from 2010 onwards, and most of us are realizing actually it's not as straightforward as that, and that the MCL can be problematic. So currently MCL surgery is increasing, but we have a problem because the anatomy has not been worked out. I think it's the hardest ligament to reconstruct reliably in the knee for various reasons. And we're having an evolution in that area. MCL injuries can be a problem. Now, the truth is, if you have an isolated MCL, which you brace, treat properly, you only rarely get a patient who's unhappy with valgus stability. So it's relatively uncommon. More problematic, though, I believe, and I hope to prove this to you, is that the MCL also controls external rotation. And actually that, I think, is much more of a problem. And I'll show you why in a minute. There's also an unusual lesion that I only detected by treating professional footballers, and they get chronic pain. And I'll show you a case of that in a minute. And we wrote this up in 2010 in the BJJ. So the MCL can be a problem. And this lesion occurs, and you'll see an injury in a minute with a player. It's not valgus, it's external rotation. And they end up with an MCL that doesn't heal properly. It's not the superficial part, it's the deep portion of the MCL So occasionally I'll see a player once every month or two, I'll have to operate on to reattach this deep MCL that's ripped off the femur and it's failed to heal properly. And if I wasn't treating footballers, I'd never have realized this existed. So here's a player who's sustaining this injury. It's his left knee, the back knee, forced into external rotation there. There's no valgus really, perhaps a little bit, but it's all about rotation. And people don't think of the MCL as controlling rotation, apart from the posterior oblique portion that controls internal rotation. Now, the posterior oblique is really just a thickening of the capsule. And I don't know why there's been so much interest in it really, but that's how it is. So this player recovered from this injury. He had no valgus laxity at all, but he had pain. And in football, when you want to bend a ball, you have to kick it with the side of the foot, which imparts a jerk into external rotation. And he had pain, he couldn't play. And this is his knee at surgery. And you can see that this is a superficial MCL here and here, and I've split it. And this is the deep MCL at the base of the wound. And as I open the knee into rotation, look at that. He has ripped his deep MCL into two pieces. Extraordinary injury. No valgus laxity, but he had a positive dial test. And here it is after being sutured back, restoring normal control to external rotation. So when we wrote this paper up 10 years ago, I didn't really understand the function of the MCL, particularly the deep MCL. There's also a problem when you have a combined ligament injury with MCL injury. And if you have persisting MCL laxity with an ACL injury, there's good data from the Swedish registry that even fairly mild excess laxity will significantly increase the ACL graft re-rupture rate. So that's got to be important. So we got interested in all this and started studying the anatomy at Imperial College with Andreas, the biomechanical engineer. And our aim was to define the anatomy, which turns out is a bit different to what is popularly thought, look at the biomechanics, and then design surgery that works. And I've worked with my colleague, Simon Ball, who's also at Fortius, knee surgeon, started it off, a number of fellows. And we've published 5 papers during the lockdown period in the KSSTA. They're online now if you've got access. And that would demonstrate what we've been doing. And what we found is that the MCL attaches to the medial epicondyle. Many people think it attaches slightly posterior. But if you've got a bony prominence, it seems logical that usually things attach to it. The red is the superficial MCL, and the blue is the deep MCL. And that attaches posterior and distal to the superficial MCL, to the femur. And you can see it's an inverted fan shape. And the front portion of it is aligned very well to help resist external tibial rotation. And so we did a classic cutting study using a robotic setup, and we applied various forces at different angles to the knee, anterior and posterior draw, varus valgus, and also internal external rotation. And we replayed the same movement and serially cut the various parts of the MCL and also the ACL. And what did we find? Well, in summary, we found that, of course, not surprisingly, the anterior tibial translation is resisted mainly by the ACL. Valgus is mainly resisted by the superficial MCL, but the most important resistor of external tibial rotation is the deep MCL. And so, in view of the fact that MCL injuries, if not treated properly, can lead to ACL graft rupture, I would reintroduce the idea that was promoted by Jack Houston all those years ago of anteromedial rotatory instability. And that is a combination of ACL, but deep MCL with it. And so the deep MCL, I would suggest to you, is a very important part of the MCL. Now, you're probably aware of some of the research I undertook at Imperial College over the last 10 years on anterolateral rotatory instability. And we got a lot of publications, a lot of press, if you like, about that, a lot of argument with the people who believe in the ALL. I don't particularly. And we popularized tenodeses as being a good thing in certain situations. And more of that later on. But we've also been looking at anteromedial rotatory instability. We published on the ramp lesion, and if you lose that posteromedial resistance to tibial translation medially, you're effectively creating anteromedial rotatory instability. So the medial meniscus is very important, but also with the work we've just done on the MCL, you can see how deep MCL lesions are important as well. And as long ago as 91, Shapiro showed that if you put external rotation, 10 Newton meters torque onto the knee, and the MCL was intact, then the ACL had a 55 Newton force on it. But if you cut the MCL, that force on the ACL increased 2.5 times. And that's obviously very important. And of course, it explains why the Swedish registry has shown that even mild MCL laxity can lead to ACL graft failure. So what do I do with my MCLs? I've just indulged myself by showing you my up-to-date research, which I think is important. I'm biased, obviously. But what do I do? Because that's what we all want to know. And if I have an isolated MCL, of course, most patients will be braced and treated non-operatively. But if there's a grade 3, in other words, it really opens up in an athlete, I'll do an acute repair of the structures, anatomic repair, and then protect it with a reconstruction on top. And I believe in doing a very short construct from the anatomic isometric point on the femur to just below the joint line on the tibia. Short grafts don't stretch, and I tend to use synthetic because it doesn't yield. We can talk about that maybe in the questions. And I use this bracing regime post-operatively, but also in those that I treat non-operatively. What about the MCL plus ACL combination, which is quite common, particularly in the UK from people who ski? Well, in athletes, I will tend to repair the MCL and reconstruct it at the same time as I fix the ACL acutely. Traditionally, and in a normal patient, I still do this. I brace them for 6 weeks, and around 3 months later, I'll do the ACL. Now, athletes will never wait 3 months for their ACL reconstruction. And so I noticed that doing it at 12 weeks, the bone was often soft, the muscle was wasted, the soft tissues were poor quality, and I realized we could do better. And hence now I go for acute surgery. But acute surgery is not easy, and it has quite a high complication rate. So you need to be in control. And that's the big advantage I have with athletes, because we have the best physiotherapy. They're also very good with pain. They're very good with stiffness, and rarely is it a problem. But the normal population, I will do the standard treatment of bracing for a period, letting them recover, and then coming down later on with an ACL reconstruction. What about MCL and PCL? Well, if you've got a grade 3 PCL, in other words, there's no step off, it's a reverse step off, then I will do an acute early reconstruction of the PCL and the MCL with an anatomic repair. But if they have a grade 1 or 2 PCL and any grade of MCL, certainly in a non-athlete population, I use the PCL jack brace, which has changed my life. The brace brings the tibia forward and allows the soft tissue envelope to heal at the right tension. And usually we end up going from grade 2 to grade 1, and a grade 1 might even end up being normal for the PCL. So that's reduced the amount of PCL surgery I do. Now, if those cases are problematic 4 or 5 months post-injury, then I can always do the surgery later on. Athletes is a little bit different, and I would probably stop at 12 weeks. What about the posterolateral corner? Now, this is an interesting anatomic area. It's a combination of the LCL, the popliteus tendon, the popliteal fibular ligament, and the capsular arches over the popliteus, so-called arcuate complex. And these injuries effectively are a spectrum from pure lateral collateral ligament injury with varus opening of the knee to pure popliteus complex injury in which there is excess external rotation. Usually, of course, there's a combination. Now, these can be isolated. They can be mid-substance, or you can pull the soft tissue off the fibular head, or indeed you can pull the soft tissue off with a bony fragment of fracture. And so you see a very wide range of patterns of injury. And of course, they could be not just isolated, they could be combined with an ACL and or PCL as well. So the question is, which needs surgery? Now, the isolated injuries rarely do. And I've learned that the MRI, it's unfair to say exaggerates the injury, but this scan on the right with the red arrow is pointing to what was thought to be a complete rupture of the LCL. And it looks like a bad injury. But this footballer played 4 weeks later because when I examined him, he only had a grade 1 laxity. And I think it's a peculiarity of the anatomy. The distal biceps splits so that the LCL goes between it. And I think it holds it together. Sometimes we inject platelet-rich plasma around to stimulate healing. We brace them off straight for a period. But this guy played 4 weeks later, and this was reported as a total rupture of the LCL. So it's rare that isolated mid-substance injuries need surgery. Those that have pulled off the fibular head, and it's usually a soft tissue peel off in the isolated injury, then they do very well with a transosseous repair with suturing. If you have some residual LCL laxity, I've found that it's well tolerated. So if a player ends up with grade 1 laxity, that's 0 to 5 millimeters of excess, then it's really not a problem. But what they don't cope with is excessive external rotation. So I'll operate on an LCL if it's grade 2 or 3, or if they've got a positive dial test. Now, we're taught that it is significant if it's more than 10 degrees excessive. I think that's a bit too much. I would operate for even 5 degrees external rotation excess. And usually, of course, you're operating on the posterolateral corner when you're doing an ACL and or PCL. So we mentioned the best way of fixing soft tissue avulsion. The best way of fixing a bony fragment that's pulled off is tension band wiring, and I'll show you that shortly. And you can see that if you can get this lump of tissue back on the fibula, then you can restore normality to the posterolateral corner, because as you can see from this MRI, the bone that's come away or the soft tissue sleeve that's come off has got the biceps, the LCL, and the popliteal fibular ligament all attached together. Get it to heal and it's normal. And so that's why you need to operate early on those injuries to get that healing. If it's a mid-substance injury, then the best way of dealing with it is to do a direct repair, mid-substance, and then protect that repair using a reconstruction. Bruce Levy's demonstrated that from the Mayo Clinic, and that's the way to do it. Unfortunately, in chronic cases, you have no option but simply to do a reconstruction, and that obviously means that there will be more of a proprioceptive deficit. Here's an example of a fibular head avulsion that I've done a tension band wire. The X-ray doesn't show you that there's a big lump of soft tissue here. And if you're trying to drill down, it's almost impossible to get a screw and washer in. So the best way is 2K wires and a tension band wire through the fibula. Now, what sort of surgery do when you do it? Well, there's one operation that very few people have heard of or do. It has a small place, in truth, in the armamentarium, but it's a very good operation. Frank Noyes wrote up a decent series of these in 1996, American Journal of Sports Medicine. If the posterolateral corner is loose, but not terribly loose, and for example, you put it in the figure 4 position, you can palpate the LCL, so these things are stretched, but not broken, then you can do an epicondylar advancement operation. On this piece of bone is attached the LCL and the popliteus. And if you create a trough and move that bony fragment anteriorly and proximally, you'll retension. But in addition, you excavate the hole and you medialize it, and that will retension and you won't lose the natural biomechanics. And as you can see, it's important to medialize anyway, because you want your screw and washer to be nowhere near irritating the IT band. So I use that on occasion if there's only mild posterolateral corner insufficiency and it's a chronic case. But the majority, I will do my repair and then I'll protect it using a fibula-based modified Larson type reconstruction. I use a long ender button across the femur. I don't like allograft. I use semitendinosus and gracilis, and I make them to be 2 separate limbs by having fixed it with the ender button, adding a screw between them. And then I take them deep to the IT band, and the anterior band goes from anterior to posterior through the fibular head through a tunnel, and then the other band goes deep to the IT band and medial to biceps, and from posterior to anterior. I tension them and then hold them with a screw, and then these loose ends are sutured back up to themselves. And this is the sort of construct, and this X-ray shows why it's so important to have the posterolateral corner, because it helps the PCL control posterior tibial sag. So this guy is interesting. He's had an ACL reconstruction, and then using hamstring tendon, then he had this dreadful injury in which he blew his graft for his ACL and also got a posterolateral corner injury. And here's his MRI scan. There's a bony fragment with the LCL, biceps, and popliteal fibular ligament on it. And he was treated by his local surgeon, and he chose to use a screw washer. And as you can see, it didn't work. And this is the post-operative film. There are skin clips. And I do not know why they didn't decide to take him back to theatre and refix it. But for some reason, the surgeon thought he'd leave it, treat it non-surgically. And the poor player presented to me several months later with an intact ACL revision. He had contralateral hamstrings, but he had hyperextension varus laxity, instability from this laxity. So the question was what to do. I don't like allograft, I don't like allograft usually, apart from rare indications, which you'll see later on. And I like autograft, but he's had both of his hamstring tendons used, and I needed a graft with 2 limbs to it. And I realized if I got a full thickness quad tendon graft, you have rectus, femoris, and intermedius. So you've got 2 limbs plus a bone block. And I measured it up on the MRI scan and felt that it was long enough to allow me to do a Larson type reconstruction. And you can see that's what I've done here. And the ends were folded up and sutured to each other. It was just long enough to achieve the goal. And in fact, he's done very, very well and got back to play at 9 months at the same level. Now, with post-lateral corner injuries, alignment is perhaps very critical. And so osteotomy is something that you should think of. But the reality is we're not yet at a point where we can advise osteotomy for return to sport. And you can see this gentleman's got a very big thrust as he lands. And he had a revision of his ACL, post-lateral corner reconstruction and osteotomy. Here he is at 16 weeks and a completely changed gait. I do think that with modern techniques, we may start doing osteotomies as athletes, but I think we're not quite there yet. Now, just finally, talk about the cruciate ligaments quickly. If you have an ACL rupture and you want to play sport, I do believe you need to have surgery. I know not everybody agrees with that, but I don't want to argue about it now, but that's my view. If you're an athlete, you need surgery, with very rare exception. When I do the operation, I place my graft, which is always autograft. The choice varies with sport. I place it in the anteromedial position in the femur, and I frequently add a tenodesis. So that's ACLs with me. PCLs, if they're isolated ruptures, then they rarely need surgery. But some grade 2, in other words, you've abolished but not reversed the step off, they will have symptoms at 12 weeks. And if it's not doing well at 12 weeks, I will operate. But I can't remember the last time I did an acute one. And the surgery, I use single bundle technique. I can explain why. And I use a 6-strand graft, doubled bilateral graftless and semitendinosis. So a big graft, often I put a bit of synthetic tape in it as well. But most isolated PCLs correctly treated non-operatively, and I've mentioned this brace to you before. As I say, it has changed our lives. What about combined injuries? Well, you've seen this picture, I'm sure, many times before, and this is a big injury. And you'd think that all of these big injuries need surgery. Well, I've learned a lot of lessons over the years. I used to have an almost religious belief that every broken ligament needed an operation, so there was nothing loose, so it wouldn't ruin the grafts that I put in for the other ligaments. This case taught me a lot. This boy slipped on a boat. He dislocated his knee, as you can see. He buttonholed the medial femoral condyle through the medial soft tissue and had irreducible dislocation. Thankfully, no neurovascular compromise. He was treated at his local hospital very well. They reduced that big fragment from the ACL and fixed it, and they reduced the knee, but they left his medial collateral ligament as it was. And I looked at that time in my career, I thought, well, these all need surgery. But for various reasons, I didn't operate. And to my absolute surprise and delight, at 7 months, he had a normal MCL, no surgery. Isn't that incredible? If you go back to that, to this, you can't believe it's the same knee. So I realized that not all of them needed surgery. And the picture on the left was treated by an older surgeon who's recently retired. And he taught me, he said, look, sometimes you can get things to heal without surgery, and then you end up doing less surgery. So both these players, player on the right's mine, I've recently met the guy on the left. They had a 3-ligament injury, but thankfully the PCL wasn't bad. The MCL was a grade 3, and I braced them. The guy on the right, the guy on the left was braced by my senior colleague, and then just simply did an isolated ACL reconstruction, and they both got back to Premiership rugby and football. So sometimes you don't need to fix everything. And this young lady, age 17, as she was here, had a horrendous injury doing this sport. And you can see in slow motion, she gets a lot of height. She's a sprinter, up again, and then dismount goes completely wrong. And she has a valgus injury, dislocates her knee. Now, she happened also, unfortunately, to be the world champion at 100 and 200 meters sprint. And this trampoline sport, that was meant to be her last ever competition because she was going to hopefully go to Beijing. In 2007, I met her. She ruptured all 4 ligaments, grade 3 ACL, complete MCL, and she had a PCL grade 2, and she'd avulsed LCL and popliteus from the femur. She also had an osteochondral fracture, as you can see, and she'd also torn both menisci. And she's meant to be the next best female sprinter that we've ever had. So thankfully, I'd met the right people who taught me well, and I did 2 operations. The first one was to fix the fracture with absorbable screws. I repaired both menisci, and I did a repair of the posterolateral corner. Now, I realized you're meant to do a reconstruction to protect it, but I didn't want to sacrifice any tissue or disturb the knee too much. And I knew I was coming back a second time, so I could always revise it. She was braced for 6 weeks. And then at 8 weeks, I did an isolated ACL reconstruction because the PCL felt good, the MCL felt good, and I used an allograft. Now, I don't normally like allograft, but she just runs in a straight line, and I cannot afford to use any of her tissue because she's a world level sprinter. And I'm delighted to tell you that a few years later, she was back running, started competing around 3 years and did well. And then in Rio in 2016, she got the bronze as part of the UK or GB 4x100 meter team. She's also got a silver and the gold, silver in the World Champions on 2 occasions since. And in fact, I saw her this morning, and she is aware that her knee is not right, and it's up and down. But obviously, she's performed very well. X-rays are normal. MRI scans are virtually normal for osteoarthritis. So it just shows you that by making the right decisions and doing the right surgery, you can get an incredible result. I think mine's the one that can't jump properly on this picture, though. So not all of these cases need early surgery, but many of these multi-ligament injuries do need early and big surgery. But the truth is, I'm always looking not to work. If there's a minor PCL, a grade 1 or 2 particularly, and particularly when it's with an MCL of any grade, I'll brace and a jack brace first, and we can often avoid a lot of risky surgery, and the surgery has high complications, as you'll see. But which multi-ligaments need surgery? Well, if there's a vascular injury, they need an external fixator and a vascular repair. If you have uncontrolled instability, it's often when you have an anterior lip fracture of the tibia, they need an early reconstruction, repair of ligaments. If you've got an ACL component, there's no hurry for the ACL. That can wait as long as you like. The PCL, if it's grade 3, you need to bring the tibia forward. Otherwise, the soft tissue envelope won't heal properly. You get a fixed posterior subluxation, which is very bad for the knee. And so all grade 3s I'd operate on acutely and some grade 2s. What about the MCL? Well, if they're opening an extension, I tend to operate because they usually have a PCL with that, and it's a grade 3 usually. If they've got an anteromedial rotatory instability causing a positive dial, and a dial test can be positive with anteromedial as much as posterolateral. So you have to be very careful not to assume it's posterolateral corner if you get a positive dial. So I'll operate on those. But early MCL surgery, because it's such a big area exposed at the operation, has a high risk of stiffness. And at the operation, I'll do an anatomic repair and a reconstruction to protect that so that we can get them straight immediately, never brace them bent, otherwise they'll never get straight, and we can get them flexing freely. The posterolateral corner is definitely an area that needs early surgery. The results of delayed surgery are certainly inferior. And we've already talked around the best way of dealing with each type of injury, as I've described. What about the rehabilitation? Well, the rehabilitation is critical, and you must not underestimate the proprioceptive loss from these injuries, and you have to go long. And if it's a multi-ligament situation, particularly with a bicruciate, I explained that it'll take 3 years for them to get to their best, and some of them will need 18 months to 2 years out of sport if they get back. And the PCL dominates the rules for rehabilitation. And the reason for that is the PCL is the one that tends to stretch. And there's a problem, as you can see, with gravity on the tibia when they're at rest. Hamstring pull pulls it back. If you flex more than 60 degrees, you stress the PCL. And loaded flexion more than 60 degrees, the quadriceps tendon pull is posterior. So there are lots of things against you. And for the healing phase of 12 weeks, you've got to really battle these 4 things. So whenever they're at rest, you need to support the calf. I use a PCL brace. I prefer the jack brace you've seen. I won't let them do open chain hamstring work for 12 weeks. I don't let them bend without certain restrictions past 60 degrees for that 12 weeks. So they either do it prone, so that gravity is dropping the tibia as they bend, and alternatively with a therapist pulling the tibia forward when they're bending. And I don't let them load the knee past 60 degrees for that 12 weeks. So even with closed chain quads, nothing more than deeper than 60 degrees. So what about the results? That's what this talk was about, really. Well, if you do non-operative management of the MCL and the LCL, they're the more minor injuries, so not surprised they do very well. I mentioned some of the posterolateral corner injuries, if they're isolated, will be playing again as early as 4 weeks. But if it's more complex or it's a big MCL, it could be 4 months. Non-operative PCL injuries, obviously grade 1s tend to recover more quickly, but grade 2s, I think are the quickest to be about 10 weeks, the longest about 16 weeks. We rarely do isolated PCL reconstruction, so I can't really tell you how long it takes to get back, but my experience is it's usually around 9 months. Now, we'll talk more about ACL reconstruction in a minute, but there's this big opening of hearts and crying and wailing that, do you know that only half of our patients with ACLs get back to pre-injury levels of sport? And it's expressed as a sentiment of failure and disappointment. But I would say to you that, is getting back to sport the most successful thing? Most normal patients are intelligent, and most normal patients don't ever want to break their ACL again and have to do the rehabilitation. So they make a voluntary decision not to get back to their sport, and therefore all of their knee scores fall. But actually, I think it's a win-win, because you give them a lovely stable knee which protects them, and they stop doing the dangerous thing. Now, obviously with athletes, that failure to get back is a disaster. But for most sensible people in the population, they like to be risk averse. So I'm not sure that failure to get back to sport is a bad result for normal patients. But for athletes, it really is a bad result. So I sat on my backside so long, 10 hours a day for 10 weeks during lockdown in London, so much that I've ruptured semimembranosus off my ischium. And I looked at data. My fellows were running around finding out about these patients. We had a big series, 450 odd elite athletes who've had ACLs under my care with minimum 2-year follow-up. And we looked at crude data, got it off the internet, phoned up the clubs. And I found that my mean return to play is not 6 months, like the clubs want, it's 10 months. Obviously, some are quicker, some are longer. And if you look at the re-ruptures of grafts, every month after 6 months halves the rate. So I'm not worried. I don't need the work. I don't need to be putting people back on the pitch at 6 months. And so I've stopped trying to rush ACL surgery, return to play. And very pleasingly, 96% of those 457 got back to play, and 90% of those were at the same or a higher level. So only a 4% failure, which was very pleasing. Many of them quarter ruptured their opposite ACL, which is worrying. What about re-rupture rates? Well, overall, hamstrings re-rupture a bit more than patellar tendon. And if you add a tenodesis, a lateral extra-articular tenodesis, you can take your overall re-rupture from 9% down to 3%. So really pleasing improvement. But if you go deeper into it and look at where you place the graft, the so-called anatomic position in the middle of the femoral footprint, or the AM bundle position, you'll see that the so-called anatomic position has a very high failure rate for hamstrings. It was 18% compared with 10.5% for the AM bundle position. Now, if you add a tenodesis, you brought it down to 8.3%. And you can see that the patellar tendon had a lower re-rupture rate of 7% when isolated, almost double when I moved to the central anatomic position. That was not a good period for me at all. But if you go back to the AM bundle and add a tenodesis, it's only 2% re-rupture, which is for a professional athlete really very, very pleasing. What about the multi-ligaments? Well, we've got 116, in fact, recently I've discovered 118 elite athletes who had multi-ligament injuries. All of the MCL injuries were grade 3. And these are the results. You can see that we have a decent number of ACL posterolateral corner, 47 cases, 87% got back to play, but only 32 of the 41 who got back to the same level, and 9 of the 41 were at a lower level. They took nearly 13 months. Whereas ACL MCL was a smaller group, 38 cases, but almost 90% got back, and they almost all got back to the same level. If you look at the Cruciate cases, then 11 of 14 got back to play, but only 7 of those 11 got back to the same level, and 4 at a lower level. And the recovery overall is a lot longer, although this was skewed by one player who took 2.5 years. What about posterolateral corner with PCL? Well, it only got 9 cases, 8 of them got back, all 8 were at the same level. So obviously that was pleasing, but it's not many in number. And the PCL MCL, only 4, all of those got back, but 1 was a lower level. But now we're talking about pretty small numbers, and it's less relevant. And overall, it's, considering how awful these injuries are, it was pleasing in that of the 116, 102 got back to play, an average of about 13 months. And 85 of the 102 are at the same level. Just finally looking at ligament laxity, because my normal patients come back, I can never get the athletes back for TLOS stress x-rays. But you can see that if you operate acutely, you get very good laxity side-to-side difference. And really all in all, it was pleasing for the lateral side, and also average side-to-side difference of 2.2 millimeters with the MCL using a synthetic ligament. So the other important thing to say is this is hard work. These athletes have almost 40% reoperation rate. Now, most of those were manipulations for stiffness, but if you take on this sort of work, it is challenging. You've got to keep fighting, and it takes a long time, a lot of effort to get them where you need to, and you have to be prepared to reoperate. And the other thing that really stands out from our data is if you operate early, and that I mean less than 3 weeks from injury, the results are better. If we look at the early group, 91 cases, 83, that's over 90% got back to play. Only 8 of those, 8.8% failed. And they got back to play at 12.7 months. And obviously just over that from injury. The late group, obviously a smaller group because I like to operate early, their return to play was very much less, at 91% early group, late group 77%. And so quite a lesson there. So finally, I just say in conclusion that with attention to detail and commitment to learning and improving your results, you can get great results. But we can certainly improve. You can see I've got a lot of work to do still. And to get a good result, you've got to make the appropriate assessment of the injury. You've got to make the right decisions. That's often the biggest deal. The surgery is not so difficult. You've got to do a good operation, which I've forgotten to put on the slide. You've got to do the correct rehab, and then time to play has got to be the right time, not before. Just need to acknowledge all the guys at Imperial doing the work on those cadavers that you saw, and these are my disclosures. Thank you very much indeed.
Thank you very much, Andy, for that excellent overview on this vast topic and sharing your tips and pearls with your extensive experience over the years. That was great. I'll let you catch a breath. Obviously, there are certain questions coming up,
Sure.
But it's good to know, a lot of, your results are quite encouraging. And as you said, decision-making is a key factor, and also is rehab. So I'll just try and see if any of my colleagues who are on logged in have any questions, and then subsequently I have a few to ask. So Sandeep, do we have anything to, or should I start?
Sir, please start.
Okay, great. Now, so what are your views? I heard your talk and we talked about hamstrings and patella tendon, which tends to be the go-to graft in our day-to-day practice. What are your views on the quads tendon, and especially this recent paper from the Danish registry, which has shown a high failure rate for quads tendon graft in ACLs? What are your views?
So I tend to use patella tendon for my soccer players. You need a rigid graft when they've often got a lot of varus on their knees, and the re-rupture rates in soccer are very different between hamstrings. And I was attracted to quad tendon because there's no doubt, although without question, patella tendon is the best graft because you've got a nice bit of bone at each end, you've got a natural soft tissue insertion to the bone, but it does hurt more. And for normal patients, they do find that more difficult. Modern surgery's improved it hugely, but the truth is patients get over hamstrings quicker. But I thought maybe quads would give us the best of all worlds. You've got a bone block, nice thick graft. And I was very pleased with the results. I used the Stort system with a partial thickness graft, very happy with it. And I read that paper from Denmark, so I stopped because I'm very risk averse. And I thought that the ideal patient for quad tendon would be a dancer because they have to bring their heels up high. They need hamstring power and deep flexion. And they also have to kneel, but also judo players use their hamstrings to lift up off the floor. So I thought those were the groups to be perfect. But I got worried like you did. But I was at the ACL study group in January. It was the last meeting I've been to before COVID. And the Martin Lind, who published that from the Danish registry, his overall conclusion was that it may be related to the learning curve of the surgical technique. So I've started doing quad tendon again. I've only done 10 of them. So the 10 I was very happy with, but I've not had a re-rupture. But I have started doing them again because I think there are some patients it would be good for. But we've got to follow up. We've got to find out which is best. There was a lot of enthusiasm like any new technique. And I must say that patients get over it really quickly. And it's, you know, maybe it's got the advantages of patella tendon without the disadvantage of hamstring tendon, but we've got to be careful to follow up because the re-rupture rate from that Danish study was worrying. But I've got a lot of good surgeon friends, Julian Feller in Melbourne, for example, Christian Fink, who developed the Storts kit, who don't have the same failure rates.
Okay, I think you highlighted a very important point that, you know, one should not be dogmatic and just stick to one graph. It has to be kind of based on the patient profile and the demands really. So I think that's quite an important point. The other thing what I wanted to ask you, I think you've already mentioned that in terms of your femoral point for tunnel placement, you've gone back to the, is it purely AM bundle that you're trying to achieve, or is it you're cheating in between?
No, so I was taught to put it in it's in the anatomic footprint. So the naughty thing about calling your central footprint anatomic is somehow it sounds more godly, more natural, better. But the AM bundle is in the footprint, so it's still anatomic. But the history is worth looking at. People were interested in the control of rotation, and they thought that doing a double bundle technique was a logical thing to do. And you know, I can understand that. But then they realized that doing double bundle didn't seem to improve things, so why not go right in the middle? That seems very logical. But there's increasing evidence now from various studies showing that probably the important part of the ACL is the AM bundle. And so the results speak for themselves in terms of re-rupture. And so in my world with pro athletes, re-rupture is a disaster. But those who still believe in a central footprint position would say, well, Andy, your knees don't re-rupture because their kinematics are abnormal and they sublux. The knee can sublux without re-rupturing, but yours will all get osteoarthritis. But we admit, and Freddie Fu and Charlie Brown have said, we admit that we have more re-ruptures, but we believe it's a better thing long term. But I wonder, because of these various Japanese study, Imperial College, various other places, one from HSS, there's a concept of the ribbon ACL that inserts along the intercondylar ridge, and then everything else is reflected fibers. So maybe the best place to be is right up in the AM bundle because it's the isometric position. And from the studies, we looked at the anterolateral problem. The anterior cruciate is the resistor for anterior tibial translation, but it's only important control, the ACL is the resistor of anterior tibial translation, but it's only important controlling rotation at extension. And in fact, we found that the IT band was the main restraint to internal rotation at 30, 60, 90 degrees. So you've got to probably pull the tibia back and hold it back. Hence the AM bundles are most important, is my view. Obviously not everyone agrees.
Sure. So you managed to reach to that point through the accessory AM portal. Is
Yeah,
that
very
what
much.
you're
I just use a standard AL and AM,
Yes.
and you can get to the AM bundle easy, but there is a risk of, as the drill crosses the mediofemoral condyle, you know, I've got to admit, I do damage it sometimes. And here's something for you. I think we might go back to transtibial drilling. That'll take us right back then.
Well, it's very important to get some honest, experience and views from you, because this is really crucial. So no, I am sure, everything's round, and what comes in, comes back again, as you say. Now, in terms of the diameter of suppose if you decide to use a hamstring graft, how much importance do you pay to the diameter when you quadruple it?
A lot. And I was looking at my data last night, I was putting it into the charts for this presentation. And of course, that hamstring data was a 4-strand graft. And I stopped doing that maybe 5 years ago. I've tripled every graft. So I have a 6-strand graft in virtually every patient I do a hamstring on. And maybe that's one of the reasons things have improved. But they're good, very good data from the Moon group. I think they published some fantastic things. Very big numbers, multi-surgeon. And if your hamstring graft is less than 8 millimeters diameter, the re-rupture rate is a lot higher. So I don't like using hamstrings that are less than 8 millimeters. Now, that's based on American population. And for the Indian population, I suspect it's fine for the diameter to be less. But I think the message is that bigger grafts are better to a certain extent. The problem is if you have a small female and you create a very big graft and they've got a narrow notch, you then have to do a notchplasty to fit that excessively big graft in. So there's a bit of a trade-off, and you have to be a little bit careful with every time. But I as I said, half of my patients are professional athletes, and so I won't compromise on graft diameter. And I I almost always will triple the graft. So almost always it's a 6-strand graft. Okay,
excellent. And you mentioned about the synthetic. Do you tend, suppose if your hamstring diameter is not adequate, would you reinforce it with a suture, like an internal brace concept?
Yeah, I think I probably would. I do that for all of my PCLs, okay. And I know there's a worry about stress shielding if you've got a rigid thing, but because I put it within the graft, it probably isn't a straight line. So there is probably a little bit of give. And, if I was worried about the ACL, I would. You've got to be careful with synthetic in the joint cavity. I'm old enough, I worked for a surgeon who used a polyester ACL. I think it was the ABC ACL. And the results were disastrous. They all failed in time, and the patients suffered from synovitis. Some got bony lysis, etc. So we have to be very careful about getting too relaxed about synthetic. But I've used a synthetic polyester MCL for years, and that changed my life because it's such a strong, rigid construct. And soft tissue grafts immediately stretch out, in my view. I know not everybody agrees with that, but as soon as I started using synthetic, the results improved. And I've not had any of the soft tissue reactions or bony lysis that people have reported. So, I think at the periphery of the joint, I think it's fine. I'm not sure about the middle of the joint.
So when you repair the MCL, you would like to reinforce it with the synthetic, as you mentioned.
Yeah. So sometimes if it's a relatively minor, that will be 2 suture anchors and a bit of fiber tape, like an internal brace type concept. The problem with internal brace is often sold as if it's 2 little stab incisions, slide it under the tissues. And I do not believe in percutaneous surgery. I believe in seeing the anatomy, doing anatomic repair, and then protecting the repair. Because And I've seen nerve injuries with the infrapatellar branch venous nerve. I've seen very non-isometric constructs. The deep end, I'm basically reconstructing the deep MCL, that short construct, short so it doesn't stretch, but it has to be isometric. So I always put 2 guide wires, put a suture between. You know, many ligaments are not isometric. The MPFL isn't, and yet you see people testing it. It's bullshit. It's not. It's only tight and extension. The ACL, the AM bundle portion is relatively isometric. The PCL isn't. The LCL is far from isometric. The reason you put the knee in figure 4 is you flex and it opens the lateral compartments, you get your scope in. So the LCL tightens an extension, but the MCL is, I think, is critical to position it perfectly. Otherwise you have terrible results. And there's a growth of MCL surgery because people realize you have to do it, but it's being done percutaneously. The companies drive it and it sells 2 anchors and a bit of tape, which is a lot of money, and it's done badly. So I believe in opening it up, reattaching anatomically, and then protecting that repair. And if it's minor, I'll use just double suture tape and 2 anchors. If it's major, I'll use the Lars ligament that you saw.
Yeah, I think that's a very good point. And in your slides on the PLC as well, you showed that, you know, you better do a proper dissection, make sure we protect the nerve and, you know, expose the anatomy well.
Didn't have time to put it in, but we published a few years ago on the compound nerve injury. And when the biceps pulls off, either with bone or soft tissue, the nerve is bound to the biceps by fascia, and the nerve is pulled up, usually into the fracture gap. And if you have a chronic one dissecting, you can cut the nerve because it's not in an anatomical position. And so you must find the nerve proximally and dissect distally. Don't look for it at the fib of the neck. But if it's a mid-substance LCL rupture, post-articular rupture, usually it's in an anatomic position.
Great. The other thing about your using the extra-articular tenodesis alongside your ACLs. Now, the stability group have recommended that for a certain high-risk group. But I remember you talking in your slides that in an athlete, you would tend to do it more often than not. So what would be your percentage in such a patient? And is it a particular type of athletic profile which determines that?
It's basically, we don't have a clinical test. Wouldn't it be lovely if we had an equivalent of a pivot shift or some way of knowing that there's excessive anterolateral rotation? We haven't got a test, we haven't got imaging, we haven't got stress radiography. So when do we do it? Well, I do it on anyone I think is at risk in the normal population. So big tibial slope, excess hyperextension, anything more than 7 degrees, I'll do it. If they're varus, if they're valgus, if they've got a family history, if their ligament lax, and if they're under 18 years of age, I do it all kids. And you can even do it when they're growing because you can fix the graft distal to the growth plate. And the under 16s have a re-rupture rate of something like 20%. It's terrible. And since I've been doing tenodesis, I've only had 1. So it's changed my life. And so I do it on people I worry, but of course in athletes, I worry more. So if they're naturally stiff, if they come no more than 5 degrees and there's no family history, no contralateral, then I won't do it. But in professional athletes of all sports, because the stakes are so high and a re-rupture is a disaster for them, they have to miss a second season. And the problem is they usually re-rupture within 12 months of return to play. So is it just awful? And it'll finish their career. So with them, I'm more likely to. So I haven't looked at my data. Actually, I've got the data, the fellows have been looking at it, but it's probably 80% of my athletes get a tenodesis, and Joe Public is about 50-50.
Okay, excellent. And your technique would be a modified Lemaire or a McIntyre?
Yeah. So I take a strip of IT band, take it deep, leave it attached to Gertie's tubercle. I take it, it's long enough that it is more than 2 or 3 centimeters from the LCL. So I palpate the LCL and decide to cut my graft, route it deep to the LCL. I then use a suture anchor to put it at Lemaire's point, which is 10 millimeters proximal, 5 millimeters posterior to the femoral attachment of the LCL. And it's very important that it's like an MPFL, you just make it taut, you don't pull on it, because if you put 40 newtons on, and if you put the foot in too much external rotation, they get increased contact pressures in the medial and lateral patellofemoral compartment. And I suspect that'll give you osteoarthritis, like shoulder surgery. If you create a fixed rotational deformity, you can't rotate in at all, you get osteoarthritis. But if you have 20 newtons only, if you fix it at the natural 10 degrees of external rotation, the progression angle, if you like, then I believe it works very well. And my data shows it protects the ACL graft hugely.
Great. And I know you're a fan of interference screws, but here you mentioned suture anchor. Is that to prevent tunnel coalition?
Absolutely right. So we've just got a publication with Dave Lee in Singapore, as a friend of mine. And maybe I'm not a very good surgeon, but when I drill a tunnel in that position, the Lemaire point, I almost always hit the femoral tunnel of the ACL. Now I know you can cheat by, technique of leaving the reamer in the femur for the ACL, then do the external and drop your hand. You need to go 30 degrees from the horizontal upwards and also aim proximally. The trouble is then there's less of an angle on the graft, so the interference screw doesn't work as well. So that's why I use a suture anchor. Or if I go more proximal and do a Macintosh type procedure, which I do sometimes, then I've got a staple, which is well away from the tunnel.
No, I think your concerns are shared by a majority of surgeons, so you're quite right in that. Talking about the MCL, now, recently there was a review in the EFERT section, I think this year, if I'm not right, because I did a little bit of reading during the lockdown as well, like yourself. And as you mentioned very rightly, reviewing your results, that when you have a joint MCL-ACL injury, the risk of the ACL failure is higher. Now, you clearly mentioned about your management plan and your decision-making thoughts. What I'd like to know from you is that suppose if you had a grade 2 MCL with ACL, in which cases in the acute situations would you go and deal with the ACL?
So if it's a professional athlete, I'd fix both within 3 weeks of injury. But they're a minority. I have a bizarre practice. So when you listen to the talk I've just given, you have to remember that my life is perhaps very different. And so what I've got to say is very relevant to me. It may or may not be relevant to you, but the vast majority of patients who have an ACL MCL do not need urgent surgery. I would brace the MCL. I go through that 2-week program, and then I would reoperate. I then do their ACL at 3 months if they need an ACL. Most do, but not all. And if they still had grade 2 laxity, I would do a repair. And with chronic MCL surgery, if the laxity is above the meniscus, and when you're scoping, you'll see it open above or below, then I do basically a capsular shift. So I do layer by layer dissection, layer 1 split, layer 2 split, and then you find layer 3, and I put figure of 8 sutures to draw it up towards the femoral attachment. And then I double breast layer 2 over it, so a bit like a Job shoulder reconstruction. And then layer 3, and then between layer 3 and layer 2, I put a synthetic tape or Lars, and then I double breast layer 1 on top of that to keep the synthetic from abrading anything else. If they have got grade 1, then it's a bit of a balanced decision. If they're going to get back to decent sport, I would fix it. If they're not, or if they're not somebody who's good with pain, somebody's going to be much less demand, then I might well leave the MCL. So that there is unfortunately a lot of art still in our business, and you have to make judgment calls. But pro athletes, I've learned by mistake, do not accept any excess laxity. I've had ACL re-ruptures because of doing that. And the thing I'm just learning now is it's not just about valgus opening. If it's valgus, it's obvious, but there is also this rotation. And you've had knees, I've had knees that aren't valgus lax, but you just know that the anteromedial tibia is coming forward, and you think, what do I do about this? So you leave it. And you usually, but not always, get away with it. Correct. And there is a significant minority who re-rupture, and the higher level activity they have, the bigger the risk.
And Andy, when you do your reconstructions for the MCL, because you're augmenting it with a synthetic, would you just do with a gracilis autograft, or still you would prefer a SEMI-T?
No, I'm pleased you asked that. I don't use a soft tissue graft at all. So I mentioned that if the laxity is above the meniscus, I do a layer by layer dissection, capsular shift, and suturing. If the laxity is below the meniscus, and I find the joint line, I split the superficial MCL down to bone, and then strip it off the tibia, drag it down, and then fix it to the tibia with a suture anchor, having roughened up the bone, make it bleed. And then on top of that, I put a synthetic. And because you've got a short graft, it controls valgus, but also rotation. So I rarely do anything for the POL. The only time I do POL surgery is if they've got a posterior cruciate problem, and that POL is oblique and helps pull it forward a little bit, and it helps bolster the posterior corner extension. But I think the POL is overrated.
But I think that's a very important point, because sometimes if we try and reconstruct every bit of anatomy, we might constrain the knee and add to stiffness. So I think perhaps what you're doing makes a lot of sense.
So what I'm doing, I'm in the acute situation, I'm going for anatomic repair of structures, reattach them or suture them together. In chronic case, I'm taking the slack out of those structures, drawing them in the line they need to be. And then on top of that, I'm protecting whatever I've done.
Okay, great.
Protection is there to mean that you can be confident, gets full extension immediately and flex without restriction. Because in the old days, I would just do suturing and I put them at 30 to 60 degrees for 2 weeks. It was a disaster because of stiffness.
Okay, yeah, sure. Now on the lateral side, I'm glad I do the modified Larson's, having watched one with you several years, and I think it does really well. Also because in India we are relying on autografts and not allografts, so we can't do the Lepra technique. But just to push you on that, is there any particular indication where you would do the Lepra type of PLC?
There's only one, and so I hate allograft, apart from in world-class sprinters and rowers. That's the other time I've used it, because the failure rate's so much higher and it's quicker surgery, but why go inferior? So you don't need to worry about wasting money on allografts. It's very expensive, doesn't work as well. And why do I use a non-anatomic fibula based? Well, if you look at, everyone says the big problem is rotational control, but the fibula is more lateral than the tibial tunnel on a Lepra type technique. And so the lever arm for controlling rotation is 1.5 centimeters bigger. So I never have a problem controlling external rotation. Possibly mine is too tight, but there are several papers now showing experiments and labs showing that the fibula-based work just as well as the Lepra-Engelbrechtsen. And then what about the varus control? Well, in fact, the limb for the LCL is identical on a fibula-based or Lepra-Engelbrechtsen. So I can't understand why you do it. The only time though, and it does happen sometimes, is if you have superior tib-fib joint instability. Yeah. And in their paper in the Medical Journal of Sports Medicine, they proudly put an arrow to a graft from fibula to tibia, and they point, it says PFL, popliteal fib ligament. No, it's not. It's, if anything, it's the posterior superior tibiofibular joint ligament. So it stabilizes the tib-fib joint. It doesn't control rotation. I just don't get it. But if you've got a loose tib-fib joint, that's quite a nice way of dealing with it.
If you had a, sure, varus recurvatum, when we do the test, would that kind of prompt you from doing a Lepra, or still the modified Larson's would do the trick?
Absolutely, I stick with a fibula base because it's posterior. It's more posterior than the tibia. That'll help it stop hyperextension. And because it's, there's no advantage for varus control because it's the same limb of tissues in their technique.
Sure. And earlier, I believe on the femoral side for fixation of the modified Larson's, you were using an interference screw and you moved to the endo button. Is there any particular reason and that would help us?
Yeah. So the endo button is for pull-out strength, but I don't want the graft spinning. I want an LCL bit and a popliteus bit. So I put the screw in, and also it separates them. It's not anatomic, but there is a 14 millimeter or 12 millimeter gap between popliteus and LCL. So it allows me to spread the graft. It's difficult to put in sometimes, but it means that at the femur, the grafts they're not in one point, they're separate. I do wonder if the Asiero might be a better technique. But what I like about my technique is that at the bottom, I can actually stress those grafts together and fit them in the fibula. But it's...
No, I think that's an important point. Now, Andy, when we finish the surgery, the knee really looks nice and stable when we've done, say, an ACL, PCL, and a PLC, or an ACL and PLC. And a few weeks down the line, even when we're following the rehab with the brace and everything, maybe a little bit of patient non-compliance or whatever, if there is a slight, so we're always comparing the good leg in terms of the varus stress test versus the operated leg. If there is a 5 millimeter laxity, and I know you mentioned in your talk, it really doesn't matter.
Yeah.
So it's reassuring to know that, that's not going to cause any problems when they return back to
But it
sports.
seems that most people tolerate varus laxity quite well. With most MCLs that are treated non-surgically end up with a grade 1 MCL laxity, and good neuromuscular control is fine. It's interesting though, with most footballers are varus, and even so they don't have a problem. And so you can accept laxity as long as the patient doesn't feel instability. But the thing that most people find problematic is rotational instability. And Jack Houston and Slocum and people like that, they really understood the knee because they didn't have imaging, they had to think about it. And so that 4-quadrant concept of anterolateral, anteromedial, posterolateral, posteromedial instability it's a lovely way of thinking about it. And when you examine a knee, you pick it up. If the ACL's gone, that happens. If the PCL's gone, it's good, it reduces it. So I examine PCL knees differently to ACL knees, because when you examine, you want congruent reduction to start your examination and then open or close, otherwise you get very confused. And I think those guys had to rely on their examination much more.
Do you rely on stress radiography intra-op or generally post-op to just evaluate outcome?
Embarrassed to tell you that we've got a TLOS, as you saw, and I've only ever used it for research. Patients don't like it. It's a nice tool, but particularly when you're looking at AP stability, it's not as accurate as a lot of people would like to believe, because the X-rays are 2-dimensional representations of a 3D reality. And you measure points, but if there's any rotational variability, then I think there's an inherent inaccuracy. So I'm not sure how useful it is clinically, but sometimes if you listen to me, you think I don't care about accuracy or research. But I do, I really passionately do, because we owe it to our patients to study and work at it. But you've got to know the limitations of the tests we have. So I don't use it routinely. I rely on my examination findings.
No, absolutely. And, it just goes with the experience, and it's a practical thing. And that's the reason to, get someone like you, because, in a busy clinic and otherwise, there are lots of things one can do, but is it really practical, or is it helpful, or does it affect the outcome? So I think those points are really pretty useful.
I would say that if you weren't sure, it might be a good thing to do, because it might give you more evidence for prosecution or defense.
Sure. And Andy, just coming to the end, I know we've exhausted you, and you've been really patient. In the multi-ligament knee, say MLK 3 and 4, in terms of the early post-op rehab, there's some kind of data coming that one should start, even though we keep the patient non-weight bearing, one should start knee flexion to at least 90 degrees in the first 2 weeks, rather than to immobilize them in extension. What are your views, and what do you really do?
Well, I do get them moving now. We have the luxury of these really expensive braces, which have changed my life. Whether I treat a PCL operative or non-operatively, post-operatively, I've got the PCL jack on and it protects my PCL. I'm definitely getting better results. The most important movement is extension. So first of all, whatever I do, every case I operate on has to have full, immediate, active and passive extension. So that's non-negotiable. The flexion, if I've got a difficult meniscal repair, I might stop it at 60 to protect the meniscus. But multi-ligaments, usually it's a distraction injury. And in fact, fortunately, the menisci usually don't rupture. It's one of the fortunate things. And so the PCL is the only one where you might restrict flexion. So post-lateral corner, it slackens or it's less tense with flexion, so no problem there. If there's a biceps avulsion, obviously it can only be passive. I don't let them do active flexion. MCL doesn't matter because it's isometric. The PCL is the only thing. If you go over 60 degrees, it does tend to stress the PCL a bit. But if you've got a good PCL jack brace on, then that shouldn't be a problem. Or if you've got a therapist pulling the tibia forward. So I don't restrict flexion. I want them to have 90 degrees by 4 weeks at the latest. I used to say 6 weeks, but I am coming further and further forward in terms of my timings. But I have a luxury of good physiotherapy. I have a luxury of PCL jack brace. I mean, it's £400 or something. It's a lot of money. So it's easy for me. And if I didn't have that facility, then I would probably brace them straight for a few weeks at the beginning.
Okay. Great. We'll keep going on and pick your brains, with all your years of experience on this complex topic. So really, personally, on behalf of the Indian Arthroscopy Society, I'm really grateful that you agreed to take time off and really give us your insight and your experience on this topic. And importantly, as you mentioned, this is a first-hand information which you're sharing with us. So we're really very fortunate to know about this. And once again, thank you very much. And I will certainly send you the link across shortly once we get it, so we have it. And we really look forward to getting you over next year, if possible and convenient to you. Thanks very much, Andy, and please take care and have a good weekend.
Lovely. Thank you very much.
Pleasure. Thank you. Bye.
Dear friends, we have very interesting webinar coming up. That's the live webinar 100. It's going to be there on 11th of October. That is this Sunday, evening 5 p.m. It is, we have named it as a Centurion webinar, Masters of the Masters. And we have very good speakers, Dr. Anand Joshi, Dr. S. Gopalakrishnan, and Dr. Dinesh Patel, both are from USA, and our other regular faculty members and Dr. IPS Oberoi. And it will be moderated by Dr. David Rajan and Dr. Bhasin. So stay tuned. Thank you very much.